they have a conference. No history of vasculitis, collagen vascular disorders, cardiac disorders
Thromboembolic
in the family. Rather than, okay, surgical history is fine. Now there is nothing like skin debridement. What is debridement? Last row, I'll start with you, I have to do that. And it's not a punishment for talking. My mind will go there only, so it will start with it. Next. You can sit down. Next is somebody else is already standing. So when you're here, just be here. And everything will get into your system. No, don't have to be sorry. If there is a question that you try to ask each other, you can very easily ask me. And let me tell you, no question is silly. Please sit down.
Skin peeling.
Skin peeling. Anybody? This is close. Removal of the dead and damaged tissue. It's close, not bad. Anybody will make it better?
So removal of dead and dead epithelial tissue is known as debridement.
It's basically to improve the healthy tissue, healing of the healthy tissue so that it becomes better. Removal of the dead tissue so that the normal skin improves better. Healing of the
Normal epithelium can grow.
Debrima means Latin to unleash. To unleash, which means take it off till it bleeds. That's debridement. What you said is surgical toilet. So there's a difference. Debridement is to take out all the dead tissue, devitalized tissue, until you reach a healthy tissue. And how do you know it's healthy? It bleeds. That's debridement, which is called debridement, which is debrima is the word. Is that clear? Everything else is a wound toilet, which can be chemical. That is, you can use chemical agents like you saw, hydrogen peroxide, which can, chemically remove the dead tissue.
Yes,
Or surgical, you can use a knife. But you don't wait for it to reach a dead tissue, a living tissue. That's the difference. So debridement is a step beyond surgical toilet. Is it clear?
Yes.
Debridement is done by a surgeon. Surgical toilet is also done by a surgeon. And dressing is also done by a surgeon. So what does the physician do? He gives love and fresh air. That's it. These wounds don't heal. Just control diabetes, also we control ourselves. So this is a surgical problem. And debridement is done surgically. There is no confusion. Debridement means surgeon. Surgical toilet means surgeon. Rest can be done by anybody. Any MBBS doctor should be able to dress it. So there is a difference. Now suppose an MBBS doctor is a slightly better MBBS doctor, he can use chemical agents to debride, which they use. And that can take care of the dead tissue. So do not say skin debridement. There's nothing like skin debridement, muscle debridement. Anything which is dead, removed till you get a healthy tissue is called debridement. General physical examination is perfect, almost perfect till here. Pulse here is very nicely taken and you should take it. Why should you take the entire pulse?
So basically we have to take all the peripheral pulses to establish if there's any blockage in any of them.
Why? Loudly. Why should you take all the pulses? You do that in medicine for CVS, but it's here very, very important.
So because it's an ischemic disease, so it can manifest in any of the pulses.
Partly right, yes.
So the patient has a history of hypertension, diabetes, so has a higher risk of having a thromboembolic disorder. So we have to check for all the pulses all the pulses if there is any delay or if there are any diminished pulses which can point us out this partial or complete obstruction of
That's
the pulses.
correct. That's right. Anything else? Yeah. Why do you? Yes. Excellent. Give him a big round of applause. Actually, you should look for all the pulses. We are not talking airy-fairy things here. We are straightforward. You will need pulse to be seen in all patients all the time, all pulses. There is nothing wrong in it. But it's a waste of time if you are doing it for a hernia case, naturally. So you get away by saying pulse rate is this, rhythm, okay. Here it's important. Whether there is a delay, there is no pulse in the lower part, where is the pulse not felt? If you say popliteal is not palpable, I'm already looking at a femoral. Femoral is palpable, popliteal is not. So where is the block in between the two?
Yes.
Similarly, if you are lower down, dorsalis pedis is not palpable, popliteal is palpable, we are looking at the space in between. Upper limb pulsations are felt, lower limb are diminished. Looking at coarctation or something related to that,
yes,
where you came in. That's the second part of the story. And more importantly, you need to understand that it's a disease of the pulses only. You need to find out where else the patient has this. Suppose he has diminished or absent pulse, which is radial pulse on the right side, and popliteal on the left side. So you're looking at a block above as well as below. So that's why it's important. The pulse here is a very important aspect of examination, and you should do that. Rather than a routine, rattling out of the pulse rate, rhythm, character, volume, etc. Vessel wall also should have been mentioned here, which is missing. That's why I was asking this question. Why should vessel wall be important here? Anjali?
So it's hardened in the vascular.
So we are looking at an etiology which she did give us. It could be atherosclerosis. In which patients you get pre-senile atherosclerosis? Loud, everybody.
Diabetic,
Diabetics
hypertensive,
and smokers.
dyslipidemia.
He's a chewer and a diabetic. So we can get atherosclerosis as a cause. So the pulse completely must be described here. Rest is fine. When you talk about performance status of these patients, there is a catch. Sometimes a patient has got fractured limbs, he cannot walk, but otherwise he is fit. Now the performance status doesn't become 40. So what would you do? You could say, I could not comment on performance status because the patient is an amputee and he is not walking. You can't apply that scale. It is to those who have got limbs but they can't walk. If somebody doesn't have limbs, perpetually his performance status is less than 40. Is that clear?
Yes.
So please understand the whole idea. Now the problem came again, and that was, what's wrong in this slide? Go ahead. I'm asking you because those who are present. Okay, he's taking ages.
Around that.
Yes.
Achha, there's no local
There's
exam.
nothing like
Local
local
examination.
examination.
Right.
Examination of lower
Lower
limbs.
limbs.
And which side would examine first? The normal side. Normal side. And what is it that you examine in a limb? What are the steps of examination of a lower limb or limb?
Inspection. Movement. Movement.
Inspection first, if any scar or any surgicals, any is present or not. And then in palpation we look for pulses and tenderness or any raised temperature or lower limb.
Movement.
Auscultation of the
That's all here.
Movement.
Why should I ask?
Movement of the limb. Movement of the range, locomotion, movement of the limb.
Yes? Please note down, sit down.
4 चीजें होती हैं.
How do you examine a limb? Forget about this case. Whether it's varicose veins, or it's a soft tissue sarcoma of the limb, or it is a gangrene of the limb, or it is a whatever of the limb. Now, attitude.
Okay.
Attitude of the limb. In what position is the patient keeping? Decubitus of choice. Visible deformity. Apparent lengthening or shortening. You're digging for something?
Yes, sir.
Visible ulcers, skin changes. And what am I doing? Simple, which you see, gait, arches. Now what is remaining? Muscles, bones, arteries, nerves, lymphatics. So, pulses,
Palpation.
any bony deformity, fractures or whatever. Joints, movements of the joints. Then, you're looking for venous system.
Yes, sir.
Look for any dilated veins, any varicose veins, etc. Edema, especially non-pitting. Pitting is for venous, lymphatic is for? Would that be non-pitting?
Non-pitting.
Then you're down to any ulcers, any ischemic part, now dry or wet gangrene. You can say blackish discoloration. And then regional lymphadenopathy, examination of spine, you're over. Now, how would I cover this then? I examined the patient in a sitting position, that's what she said. This patient is not willing to wake, stand up, that's okay. I examined the which side is normal. Both are affected. Which side is less affected?
Right.
You can't make out? Okay. So the attitude of the limb, how was he sitting?
So he had both his legs like in the flex position.
Hanging down, which improves the circulation, which is a feature of ischemic limb. A Burgess disease patient would be always hanging his limb down because it's painful. So he hangs it down. And sometimes he'll sleep all night with the limbs hanging. That's what I'm talking about, decubitus of choice. So the decubitus of choice here is flexed knee, flexed hip. I'm just repeating what you're saying. There's a visible blackish patch, and this is an amputation stump, which is above ankle or below knee, you can call it. Other side is not visible here. And what is the other thing that you look at? Any muscle wasting, any ulcers, any skin changes, any dilated veins. They will all fall into place. Clear to all of you? Yes?
Yes, sir. Yes, sir.
Now a round patch of raised skin of, this is not what you're looking at, it's a blackish patch over the knee joint, which seems to be affecting an area which is mentioned 60 to 5 centimeters. And the surrounding skin, if you enlarge it, you will see as whitish area, which is actually desquamation. It is desquamation, but the squamous layer is gone. What are the features of chronic limb ischemia? What are the features of acute limb ischemia? We'll discuss. But before that, you can find that in your examination. The well-defined margins is over the knee. You can actually feel it. This is the other limb. Is this the other limb? You can see here the features that I was talking about.
Dilated veins.
Dilated veins, muscle wasting in a flex position, blackish discoloration here. If you remove the dressing, you would have seen this. There's a line of demarcation and loss of hair. These are all features of chronic limb ischemia. So on examination, you can automatically find it. Can you see the dilated veins?
Yes, sir.
They are visible, but they are not varicose veins. What is the characteristic of a varicose vein?
Tortuosity.
Why are they tortuous?
Perforators, the deep veins chronically push the blood into superficial veins, so it becomes dilated and tortuous.
Why tortuous?
Because increased blood.
Because of dilation.
Why tortuous?
Tortuous का नहीं.
Because when you extend the length, the veins need to expand. So physiologically, they are tortuous.
Correct.
Excessive
The limb
blood
length is not increasing.
Hmm.
The vein length is increasing. It has to be accommodated in the same length.
Yes, sir.
Like a snake, it will have a tortuous.
Tortuous.
That's why varicose veins are when you have dilated and tortuous veins. You can't just say dilated veins. And they are tortuous on account of lengthening, which is on account of filling of the veins. Now what you are talking is a cause of, one of the causes of varicose veins. That is, the perforators are incompetent, so deep to superficial lymph flow, or prolonged standing leads to DVD or deep vein is blocked. So there are superficial system which is flooded, etc., etc. I don't think that was fine. On palpation, this is very nicely done. You can actually see superficial, temporal, facial, everything. The popliteal is absent on which side? Both sides. Femoral? Absent? Present. Now this is here, auscultation is fine. You would like to find out whether there is any growing due to stenosis.
Yes, sir.
And that you would normally hear at the femoral. How do you palpate for popliteal? How do you look for dorsalis pedis? You have to watch it sometime in the ward because this is important. Something which is asked in the exam, and almost invariably you get a case of ischemic limb. One person definitely gets almost always. And we ask them to just show me how to examine for dorsalis pedis, for popliteal, for femoral, etc. Now, systemic examination is done, S1, S2, no added sounds, now no abnormality. So, cardiovascular system becomes important here because it could be a source of embolism. Something is missing, which I'll tell you what is that. The respiratory system is fine, abdomen is soft, non-tender, bowel sounds. Look, we are not interested in bowel sounds here. Otherwise, it will be a different case. You can say abdominal examination is normal, and you must look for abdominal aorta.
Yes, sir.
That's what is the intention here. And what do you look for in aorta? Atherosclerosis, hardening. It could be a aorto-iliac disease, ilio-femoral disease, femoro-popliteal disease, popliteo-dorsalis pedis disease. This is a ischemic map. So if there is examination of a limb for vascular causes, always examine the abdomen for abdominal aorta. If you are doing Duplex scan for the lower limb, always do the ultrasound of the abdomen for aorta. And you know why? Because that could be the source of the trouble. So here bowel sounds won't bother me. They are normal actually, otherwise he would be having a different complaint. Summary. It is a good history for an ischemic limb, let me tell you. The presentation was also above average, but the mistakes have to be taken home by all of you. Anyone, including postgraduates, when they make their presentation on vascular ischemic limb, they don't do it well because they don't learn it that way. Now today I have actually not taught you ischemic disease, I have taught you about examination of a limb. Now if I ask you to examine a normal limb, you should be able to examine a normal limb also on the same headings. You don't need a diseased limb for this. I'm repeating, attitude.
Attitude, position,
Okay.
So attitude, decubitus, deformity, then your aberrant changes in length, visible ulcers or skin changes. Then you come on to your gait and arches, and finally you come on to
Final very fast.
muscles, bones, you examine the muscles, the bones, the arteries, the veins, the nerves, and the lymphatics. So in muscles you see the movement and the tone, the muscle tone, and the movement. In the arteries you check for the pulse and describe the pulse. In veins you check for ulcers and dilated veins in the skin, tenderness and redness and itching in the skin. And in lymphatics you see for lymphadenopathy.
You are big round. Now that's the problem with me. I'll have to change things and add a few more. The examination of the limb. I am repeating. Look how idiotic one can be. I must be repeating it a million times, but I'm still willing to do it so that you remember. And with one attempt, he could repeat this much. I'm so glad. So I'm actually thinking about telling you even more because I look at how much you are receiving. It's very obvious. Just imagine a person standing in front of you. How does he stand? How does his limb hold him? That's the attitude. Decubitus of choice, what can it be? In varicose veins which are prolonged and delayed, they have equinus deformity, so they stand on their toes. Patients with compartment syndrome are not able to move their limbs, ankle joint, because it pains. Patients with Burgess disease or ischemic disease of the lower limb, they hang their limbs down. Patients with venous causes lift their limbs up. Look at the visible apparent lengthening and shortening. Real lengthening and shortening is calculated by measuring, you know that. But apparently you can find one limb is long and the other is short, which could be also postural. So you make the patient walk. That is gait. Then you look at the skin. Any changes, ulcers, loss of skin, dilated veins, scratch marks, as he mentioned. Then you look at the muscle wasting, which is obvious. You later on measure it. Then you look at the movements at the joints. You coming down, you look at the soles for any callosities. Callosities would indicate the position in which the patient is walking. Diabetic foot patients and diabetics lose the positional sense with the joints called Charcot's joints. So when they lose that positional sense, they walk in a very wonky way. And when they walk in an abnormal way, the weight bearing is at a wrong place. And that's how they develop cracks and ulcers, and that's how diabetic foot develops. That's why it is important. It's not just for the sake of completion. And then you're looking at wasting. Why? Muscle wasting would indicate chronic limb ischemia. I will discuss that. You're looking at any ulcers would indicate underlying venous disease or arterial disease. Where do you find the arterial ulcer? You don't find it? You're saying you don't know.
I don't know.
Around the facial areas in the digital
They are farthest away naturally. If the river is drying up, which is going to be the first place of drought.
The farthest, the periphery.
If the river is getting flooded, again the same place.
Periphery.
This is the end. So ischemic ulcers develop at the terminal part of fingers or toes. That's the reason. And how do they look? They look completely punched out edges. They like eaten on. One of the important features of chronic limb ischemia is tissue loss. Patient will give you a history that my toe is dropped after a while. It died and fell. Nails, brittle nails. I'm expanding on those points now. Add up, brittle nails, loss of hair. Why is the hair lost in chronic limb ischemia?
loss of blood supply.
Naturally. How does skin get its supply?
Cutaneous.
How do they get it?
From the
Sit down.
main arteries.
How does blood reach the skin? Tell me the story of a blood cell if it has to reach the skin.
There is blood supply to the dermis.
Quickly sit down. No, it's not right. That's not right. Sarthak,
Cutaneous tissue.
how does it reach there first of all?
From the main arteries to the patient.
Anybody here? There is a red blood cell which has come into the femoral artery and it has to reach the skin of the foot. So it will get into the popliteal and then into the anterior tibial
Communicating arteries.
and then it will go through the muscle, fascia,
Perforating arteries.
perforators, dermis, skin. Superficial. That is epidermis. Stratum corneum is the first layer, top layer, which keeps dropping off. So they keep losing stratum corneum first. So one of the earliest features of ischemia would be top layer gone. That is called desquamation. With that go the hair. With that the nails become brittle. Then the next layer. You don't know anything about it, next layer. Then forms an ulcer. Before ulcer forms, it's blackish and all that stuff would happen. Then gradually, then the limb is gone. That's the story. Have you understood? If it has to go this way, it has to affect this way, So the top layer goes first. Stratum corneum is lost first. If you lose stratum corneum, you lose hair. It's an early feature of ischemia. And you need to look for them in the limb. Ulcers, skin changes in the form of hair loss, pigmentation, brittleness of nails, tissue loss, ulcers, etc. Varicose veins. There will be dilated veins with blackening or blackish discoloration of the lower part of the which area gets the varicose ulcers most commonly? Median malleolus. Last row. Gaiters area. Gaiter is what?
The dependent part.
It is what soldiers used to wear for covering up their ankle with a bandage so that the snake bite doesn't. The problem was snake bite. So they would cover that with a patti. That was a gaiter. And we tied into the anterior tibial, the lower part of the leg, covering the lower 1/3. That's where the ulcers are most common. To explain it, in front of the pretibial area, that's bare area almost. That's a common site for varicose ulcers. So which is the commonest site for varicose ulcers? Gaiters area. Which area?
Gaiters area.
Now, so you will find an ulcer there, you'll find dilated tortuous veins, you will find blackish discoloration there, that will go in favor of chronic venous insufficiency, which includes varicose veins. It's not just varicose veins. Clear? That's what you need to look at for the limb. And then you conclude by examining the regional lymph nodes and spine. No examination of lower limb is complete without examination of
Spine.
Clear? Many diseases of the limb or lower limb have their origin in this spine, like pot spine, Schwarz abscess, and one very important cause of claudication, which is a differential diagnosis of the claudication that you have, is neurogenic claudication, which is due to lumbar canal stenosis. Spine has to be fusion. Lumbar
Canal stenosis.
How would it differ from the one that is caused by Burgess disease?
Pain start in first step in neurogenic, and after some
Just the opposite of what you get in claudication. Initially pain, then
Starts in
disappears.
this.
Clear? What is rest pain? So what is that? What is the cause of it? It is a cry of dead nerves. So that's the summary. Now the diagnosis. "50-year-old gentleman, chronic smoker, known diabetic, has features of chronic limb ischemia in both limbs, right or left more than right." How would you differentiate chronic limb ischemia from acute limb ischemia? One is in history and then on examination. What would you observe in history? Duration.
Duration.
Acute is acute, so it's quicker. Chronic is of prolonged duration. Which type of gangrene do you get in chronic limb ischemia?
Triangle.
Which type of gangrene do you get in acute limb ischemia? Why?
So people like is usually due to acute vascular occlusion, so vascular
Vascular occlusion.
Okay.
So the blood gets stuck there because of the sudden obstruction. So there is weight.
Rohit?
No change.
Sorry?
Right, usually due to
Green shirt, just stand up.
Usually due to arterial causes. Blood gangrene.
Can this go up? Then I can
Yes, sir.
And dry gangrene will develop because of venous causes. That's why it takes longer time.
Dry gangrene due to venous cause. Why should gangrene develop? It can develop into venous, but that's not the... gangrene is what? How do you define gangrene? Definition of gangrene.
Okay.
Is death of a tissue gangrene?
Necrosis. This is necrosis.
Necrosis plus infection is gangrene, no?
Gangrene.
There has to be infection also.
Yes, sir.
The mere death is not the case. Now remember, I'll show you today and you should remember forever. And those who don't see it today, they cannot make out from a video also. They'll have to understand it. And there's no replacement for understanding it here. Watch it carefully. This is the terminal part. That's an artery. And this is a vein. And this is the heart side. Blood is flowing like this, like this. Is that clear?
Yes, sir.
Clear so far?
Yes, sir.
Yes?
Yes, sir. Yes, sir.
Remember one thing very clearly. There is no artery or vein which is not enclosed in one sheath. That's nature's system. Carotid, carotid sheath. Femoral, femoral sheath. Popliteal, popliteal sheath. Now, both being in the same sheath has a purpose. What is that? Artery has its own pulsations. Vein doesn't have any muscle. So the venous drainage depends on two things. Pulsations of the artery and the breathing. Inspiration, negative pressure in the chest, blood sucked up from abdomen. Please don't yawn. It is infectious. Now, from limbs to abdomen to chest and to the heart. Now, what do you do with an artery alone? The flow would be with pulsations. Vein, it will drain. Is that clear? I'll ask you to repeat it. Now, if they are in a sheath, the vein utilizes the pulsations of the artery. Am I clear?
Yes, sir.
Now, if I block the artery partially, the supply to the distal part is reduced gradually, but pulsations are there, so vein continues to drain. So the end will become dry. So there is a chronic limb ischemia, which means gradual narrowing of the artery. The venous drainage is persistent, arterial supply is reducing, that leads to a dry gangrene. Is that clear? I want to hear a good yes if you have heard it.
Yes, sir.
But this is the basis of a lifetime. Understand it. You can't read it anywhere, I can assure you. Here is one of my top registrars here, he's one of the best ones. Even he has not read it. They don't read it anywhere, it's here. So therefore pay attention. You getting my point?
Yes, sir.
If you block it suddenly, thrombus or embolus, you block it. The vein also will block because there is no pulsation. There is pooling of blood and cutting of blood supply together. That is wet gangrene. So acute is thromboembolic. Chronic, gradual. This is the reason for dry and wet gangrene. Everything else that you've read is absolutely wrong, I can assure you. Therefore, chronic limb ischemia is associated with dry gangrene, line of demarcation, shriveled skin, dead part, and absent pulses. Wet gangrene, edematous, you can't see anything there. Suddenly edema. I'll give you an analogy, pay attention. Just take your mind off here to the ring road in front. South X is your limb. Dolakoma is your heart for the time being. On your left side is the artery, right side is the vein. Road that side, road this side. Clear? I put a barrier on the arterial side which allows two vehicles only. But this side is free. South X will dry up. Everybody will go, but very few people will be going. Clear? I put a barrier right across. You're stuck. That's wet gangrene. First one was dry gangrene. Now sometimes a dry gangrene gets infected. Looks wet, but it's not a classical wet gangrene. Is that clear?
Yes, sir.
I mean, just because a dry gangrene became wet due to infection, that's not what wet gangrene is about. So what are the features of chronic limb ischemia? You repeat now.
So in chronic limb ischemia we have dry gangrene, there will be lots of pulsations and gradual loss of hair, thinning of subcutaneous fat,
Shriveled skin.
little nails,
Shriveled skin. Shriveled skin.
changes will be there, discoloration.
And this stuff.
Muscle wasting. Muscle wasting.
So let's start with what we started with. What will you have in the history?
Sir,
Claudication.
Claudication. Pain.
History of claudication, which is moved on to become rest pain.
Yes, sir.
Some etiological factors like smoking,
Smoking, hypertension.
old age, etc., diabetes, and gradual development of the process with visible changes in the skin, in the muscles, in the bone, in the limb. We are not discussing them, we already covered. Wet gangrene, sudden in onset. No claudication therefore. Can there be wet on dry gangrene? Yes, either by infection or there is a block in the femoral and then it throws the emboli to the terminal part and you have wet gangrene of the toes. Both can happen. But the etiology is clear. Now you clearly understood what it is. Suppose the block is much higher up. Examination of cardiovascular system becomes important to rule out a mural thrombus or SABE, subacute ventricular endocarditis, or something which leads to
Embolism.
showering of emboli. Therefore, history of blackouts is important. Loss of TIA is important.
Pulmonary involvement.
Therefore, chest pain is important. Therefore, palpitation is important.
Yes, sir.
Therefore, the entire cardiac history is important. And therefore, the history of abdominal angina is important.
Yes, sir.
Abdominal angina, I have told you, is claudication of the abdomen.
Yes.
So, if the block is in the aorta above the supramesenteric artery, patient will have abdominal claudication, limb claudication, he'll have everything. That's the basis. Is that clear?
Yes, sir. Yes, sir.
Yes?
Yes, sir.
So that's our diagnosis. 50-year gentleman, known smoker, a known case of diabetes with chronic limb ischemia involving both lower limbs, right more than left. Finished. Don't have to say dry gangrene of 1 inch there, 2 feet there, 1.5 centimeter here, then you keep going places. There is no point. Chronic limb ischemia, now let him ask you, why is it chronic limb ischemia? That will be visible in the description. Why did this patient has acute limb ischemia or chronic? Chronic. And I don't need to explain now?
No, sir.
Does it need explanation?
No, sir.
It's a case of chronic limb ischemia affecting both lower limbs. I can put it the other way around also. 50-year-old gentleman with chronic limb ischemia affecting both lower limbs, right more than left, and he's a known diabetic. That's it. Why is diabetes important? Because diabetes involves the large vessels, small vessels, both.
Sir.
How does it involve the large vessels? By atherosclerosis,
Okay, sir.
presenile atherosclerosis.
Yes, sir.
How does it involve small vessels? Microangiopathy.
Microangiopathy.
And how does it does? What is a diabetic foot?
Patient does not feel pain due to damp muscle.
So it's a foot
Yes, sir.
in a diabetic that has got arthropathy, angiopathy, neuropathy, osteopathy, and dermopathy. Any of these. Diabetes is the basis. Nervous system, wherever it is, neurological system, wherever it is, relies only on two things: oxygen and glucose.
Yes, sir.
That is why it was generally believed that vegetarians think better. That's not been proven right, but generally they think so. Because lots of glucose, lots of fresh air, oxygen. And with the non-vegetarian food, they link various substances that generate free radicals, which block oxygenation. It's not unusual to hear that vegetarians, especially a lot of them down south, were usually with a higher intellect, they could understand, remember better. But it couldn't be proven. That is a different story. Anyway, we are not going there. So we are talking about microangiopathy. What does it do? It cuts off the nerve, blood supply to the nerves, leading to neuropathy. Now glucose is also not available. Why? Because they have deficiency of insulin, which leads to poor metabolism. I'm sure you have a rich glucose in the tissue, but that's not being utilized. Nerves don't have the sensation, so there are tingling sensations, loss of sensation, Charcot joints, which is arthropathy. The patient doesn't walk the right way, the weight bearing is at the wrong points, the ulcers develop, which don't heal because there is poor blood supply and a lot of sugar. So imagine a situation where the tissue is laden with sugar but has no sensations and has minimal blood supply. Can there be a more ideal situation for a bacteria?
Best situation.
So bacteria gets a candy, nobody is there to stop him, so they just freak out. That's a diabetic foot. That's why a lot of people correct the local insulin supply by insulin dressings, insulin injections. Nobody knows whether it works. The whole idea is if you can give insulin there, oxygen there, blood supply can improve, the wound will heal. Therefore, when you're managing these patients, you have to take care of his blood sugar first. If you ever attend the rounds along with diabetic foot, when the moment you reach there, how much is the blood sugar? We need a diabetic control. Next, we need care of the local part, dead tissue should go so that bacteria go. Then we need to put some oxygen there, hyperbaric oxygen. It will heal. That's a diabetic foot, that will happen. Here, there is a dry gangrene with other features that are suggestive of chronic limb ischemia. That's actually the case. When you talk about the case, that is what will happen. Now, how do you approach it? Yes, yes, you only answer. What do you do now?
Investigation to support.
Speak loudly, please.
Investigation to support the diagnostic.
Support what? When you don't have it. Investigation to confirm the diagnosis. First you'll have to confirm. Okay, to support and to treat. Please sit down. What do you do to confirm? Speak loudly.
Ankle brachial index.
Ankle brachial index. Okay? The picture is gone. How do you do ankle brachial index in the limb where there is no ankle?
Your Doppler.
One is covered with bandage, the other there is no ankle, so how do you do it? Have you heard of parakeets? There are many types, rose-winged parakeet, Alexandrian parakeet, and there is one which is red-wattled parakeet. It tends to repeat more quickly what it sees. Don't do that. Think before you speak.
Doppler.
That is making sense. Ankle brachial index is done when there is an ankle. Because that is supposed to be done with dorsalis pedis. Patient doesn't have anything beyond popliteal. Is it doesn't? Popliteal is palpable. There is nothing you can do there. If the patient had popliteal pulsation, I would have insisted on one more thing which I did not. In all these patients, I am repeating, all patients with ischemic limbs, take blood pressure in all four limbs. Examine pulses in all four limbs. Auscultate from Bruin all four limbs. And you should calculate ankle brachial index in all of them if you can. How do you calculate it?
To put pressure on the dorsal, in the posterior artery and in the brachial artery.
What is it normally?
So it's a point above 1. 0.9 to 1.2 is normal.
Yes, 0.5 to
0.4 to 0.9 is independent cortication and 0.4 is critical limb ischemia.
critical limb ischemia. Well, if this was your comfort zone and you wanted me to come there, today I have come. In exam I won't come. This is how I examine. You wanted me to talk about it. So how would you bring me into your comfort zone? I'll tell you. Sir, if this patient had a lower limb, I would have done blood pressure examination, all the four limbs, and I would have also calculated ankle brachial index for taking a decision about amputation or not doing amputation. What is ankle brachial index? Now you got him in your territory. Like this I won't go. Patient doesn't have a limb and you talk about ankle brachial index, you had it. Do you get my point? That's an art of answering question. Please sit down. Now you know ankle brachial index is also rattled out. We will look for about 1 and usually 0.5 to 0.9 you still have symptoms. Below that is critically ischemic limb. Here we have a patient with, the picture is gone, I was shown you, with a limb which is quite emaciated. It's actually a wasting which is, how do you measure for wasting? Did you measure for wasting? There you are. So you won't be allowed to move if you don't measure the wasting, because you'll have to highlight it.
Anteroventric measurement.
How do you measure for wasting? I'm writing down the skin, bones, muscles, arteries, veins, joints, lymphatics. Skin changes, bone related issues, muscle, wasting, tone, movements, flickering, etc. etc. Arteries, pulses, veins. You did not look for the Berger angle. How do you look for that? You did not look for guttering of veins. What is guttering of veins?
Thinking out of the limb or elevation. If the limb is elevated,
When the limb is elevated, there is guttering of veins, which is usually due to, because you're relying again on arteries. So in a normal person, if you lift up the limb, arteries, the Berger angle is where the pulses disappear, you know that, and you will be able to still drain the veins because of the pulsations. But if they are absent, it won't happen. That's why you look for guttering. They are empty. Please sit down. Now all the other features we have seen now, so we proceed for investigating this case. What do we do? This happened. So, no, yeah, you can answer. What do you do next?
Investigations to support
To confirm what you do?
so first to confirm, so we did, so in this case we can't do it.
Doppler.
Doppler.
Yes.
Duplex. Duplex pattern.
Okay? Anybody else?
Duplex.
Actually, Rohit.
Duplex.
Duplex scan, she's saying the same thing.
Okay.
Duplex scan, including the abdominal aorta,
Abdominal.
green shirt. This will be enough. Now what is the problem here? You know why you are people wrong?
So we also assess the renal assessment. We also check for renal because when we are making a DD, we can look for a small, middle, or large artery. So in this, since it also has a middle
Okay,
small artery.
Now I'll sort it out. Any patient with a chronic limb ischemia, diabetes, etc., it is examination. Let's look at examination. Examine the patient, the limb, then the ulcer or the gangrene. Okay? Patient, limb, ulcer. Investigate the patient, the limb, the local parts. Management, patient, limb, then the local parts. Clear?
Yes, sir.
What would I do, for example? He's a diabetic. So I'll get the blood sugar, lipid profile, liver function test, nutritional status, albumin, everything is tested. Clear? And then I'll come down to limb, duplex scan, including the abdominal aorta. Then the local part, X-ray of the foot, osteomyelitis, changes, management of diabetes, management of nutrition, management of lipid status, antibiotic cover, limb, offloading devices, that is not weight bearing. Patient should have something which takes the weight out of it. So patient doesn't walk on a diseased limb. So offloading devices, debridement which is happening, sending it for culture, finding the right antibiotic, using that antibiotic. Where do you take the culture from? How do you take the culture?
Ball.
From the wall.
Not sure.
Speak loudly.
From the edges.
Edges, Anjali.
Margins of the
Margins, edges.
Edge I've seen.
In a diabetic ulcer,
It's ulcer with edge.
so
Biopsy.
here the infection is deep inside because of anaerobic infection. And you have to take a deep culture with tissue. It doesn't work with pus. There will be only commensals, you will find nothing. And you're looking for anaerobic infection, it has to be an anaerobic scenario. Also for fungus, which is commonly the cause. So in a diabetic foot, you take deep tissue biopsy
Deep tissue.
for finding out the infection. Go read any book, you won't find it. This is not how you will understand it. You getting my point?
Yes, sir.
There's no point missing out. Make it a point to attend. This is a complete information about a diabetic foot. Patient, limb, foot. Treatment's the same. Investigations I've already told you. Then we get down to debridement, which I've told you what it is. And if it is not healing, amputation, because that would be an indication for amputation. What are the indications for amputation? You stand up. Base. Stand up. Indications for amputation. Keep standing for some time.
Trauma embolism.
Anybody? Next.
Triangle, trauma embolism.
Here. What are the indications for amputation?
no blood flow in the gallbladder. Left side.
Gangrene, dry gangrene.
Dead, deadly, and dangerous.
अच्छा. Dead, deadly.
Don't talk absurd things like base. Make a base out of it. You understand? The fungus will grow there then. You will be in serious trouble. Now, take biopsy from deep tissue so that you can find anaerobes. And debridement should remove all dead tissue till there is oxygenation. Is that clear? Dead, deadly, damn, nuisance, all 3 Ds. If it is dead, you must remove it. Deadly means it will kill the patient, like gas gangrene, malignancy. And gas gangrene is caused by anaerobes. They lie deep. And what would X-ray do in that? Back to you. How will X-ray help?
Air pockets will be.
You see the gas form. That's why X-ray is important. Not only for osteomyelitis, but also for gas. So do you understand what did I tell you? Those little 3 liners that you got. Everything is covered. Examine the patient, the limb and the foot. Investigate the patient, the limb and the foot. Treat the patient, limb and the foot. For treating the patient, I have already done that part. Foot, take a good culture from deep. Get an X-ray to look for gas gangrene. Prepare for amputation if it is not healthy. For indication of amputation, dead, deadly, damn nuisance. Damn nuisance is a wound which is chronically contaminated or infected. It's causing a lot of trouble to the patient with multiple sinuses, osteomyelitis. It's not healing. But in diabetic foot, we try to conserve the limb to the extent we can. Is it clear now? Clear? And usually it is possible to save the limb with a good debridement, good care of the foot, the care of the patient. The problem with these patients is they lose sensations in the limb and tissue is smelling of glucose, and if they are not kept protected, sometimes the rats take away the part and patient doesn't know. And many a times the rats take away the dead part, patient not even knowing. In the morning you find there's blood all over the place. So you have to provide them good cover. There's nothing funny about it. The patient suffers and you have to take care that the dead part is not left there. And after the rat bite, patient can't tell you the rat is bitten. They are covered. The care of the foot has become very, very important. They should be covered in good dressings. There is a rule of hyperbaric oxygen. Unless it's not available, that's a different story. What is hyperbaric oxygen?
It's a high pressure oxygen.
There are hyperbaric oxygen chambers where there is oxygen under pressure, which can be supplying the dead or the part which has got less of oxygenation. Why is it important? Because you need to provide oxygen to the part. And if this oxygen is provided, it does 3 things. 1, it rejuvenates the tissue, it kills the anaerobes. The anaerobes cannot survive in the presence of oxygen, so it's a therapy. And 3, it stimulates angiogenesis, so there is growth of epithelial cells. So all these are important issues. Some people use some tissue factors for healing, that's advanced. Plasma factors, etc. Stem cell for dressing, etc. They are beyond you. But offloading, care of the limb, care of the patient, nutrition, diabetic control, these are the hallmarks. And amputation is the last option, which should be done if you find the limb cannot be salvaged and it is killing the patient by septicemia. Is that clear? It's usually a case in the exam, and most of the aspects we have covered, including the part which is related to diabetic foot. Part of it is diabetic foot also, because even there, what is necrotizing soft tissue infection?